a little different talk that I came up with. I think it was 2 years ago, and I've been upgrading it just because it's been well received. So I figured I shared that with you guys. So just a quick background. I'm at Connecticut Children's, which is in the state of Connecticut in the United States. I was the emergency ultrasound director here for about 10 years, 2015, 2025. I did PPEC in 2020, and then I'm the co-chair of education of the P2 network. And then what I'm doing now is I'm the medical director of emergency medical services and transport medicine here, and that's what I took over last year. But I still doing a lot of ultrasound, but I decided to give that sort of time and a title to my colleague here, so he can sort of like he's early on in his career, so he can start developing that. So, but it was a bittersweet moment when I let go of the ultrasound directorship for the ultrasound because that's sort of what I've done. But and I think I continue to do so. But just give you about that, and then let me just excellent. So should be a really quite, this is something that I'm going to be using Poll Everywhere, which is going to give you sort of to make it a little more interactive. So keep everyone awake during this time. So if you can log into that or scan the QR code there, then we can get some participation and basically I'll be using some questions throughout the lecture as well. So I'll give you like 5 seconds to log into that and we'll proceed.
I can't get it to open. Is anyone else managing?
It's it's on the screen as Poll Everywhere, but it's not. Yeah, it's not opened as such. Let me try that one. Is
Yeah,
that the
try
same
this
one?
one. If not, then I can do it without, and I can just run through it.
That one is opened.
Okay.
Yeah.
Awesome. All right. So the other one's not working, so I got to remember that. All right, excellent. So I'll give you 5 seconds, like a couple of seconds to log in, because I think the first slide I'm going to do is the actual question. So, all right. Looks like someone just came in. So I'll give a couple of seconds to join the poll everywhere so we can sort of get started from there. I think everyone should be pretty looks like then. All right. So all right, so the first one is just to make sure everything's working correctly with this is sort of like something I'd like to ask my lecturers just to get an idea of the audience. So the favorite beverage to get you through lectures. So, and I want to see if that is working and if you guys are able to answer that question. Great. This is my testing question. Love it. Beer. Excellent. He's in a latte. Okay, interesting. When I done this lecture, I asked this question here, there's a lot of like those caffeinated drinks, energy drinks. That's what pops up. That's where most people. And then I'm always interested in all the names that they have there. So, but all right. So the first, we're gonna start with a case. So I have a 20-year-old with his history of Canaboid syndrome, presented with abdominal pain and emesis. Symptoms were intermittent for the last couple of weeks. Abdominal pain was non-focal. Emesis was non-bilious, non-bloody. And otherwise, her review systems were negative, so no fevers, no recent illnesses. And then this is their second visit to the ED in the last week. Physical exam, vital signs are there. So not febrile, pulse a little high at 90, respiratory rate was 16, blood pressure is 128 over 75, O2 sats were 100. She was in no apparent distress. Abdominal pain was non-distended, but there was diffuse abdominal pain. There was no focality, and then rebound was kind of like ambiguous whether or not it was present, but that was sort of what she presented. Labs that were obtained were completely unremarkable. They included CBC, a liver function test, kidneys with electrolytes. Everything was negative during that time. And then a right upper quadrant ultrasound was ordered, and then the gallbladder was unremarkable, and all they showed was distended loop of bowel noted. At that time, one of our very experienced residents from the ED was very interested in this case because of the distended loop of bowel, and then decided to sort of grab the ultrasound and got this view. So I'll show you a couple of images before asking you guys a question. So here in this view, are you guys seeing my pointer?
Yeah.
Yep. Yep.
Excellent. Great. Thank you. All right. So here we see the gallbladder, and then we're seeing this AV loop of bowel. Unclear what it is, but there's moving. So that was sort of like the point of interest. So decided to get a couple more views, trying to kind of see what is that. Is that one single bowel? Is that what is like just stool, maybe a mass? So the couple of next views are basically is the resident trying to determine what is that. In this case, we're using a curvilinear probe just because we're in the abdominal and trying to get a better sense of what's going on in that area. So the last two slides kind of showed in a transverse um, view. So then we did a sagittal view, so longitudinal way, to kind of see what's going on here. Again, for reference, the left side of your screen would be the head, and here you see the gallbladder peaking right in this area right here where I'm showing. And the liver is right next to it, so that's here. But then we have this kind of like undetermined like mass or something just completely taking over the whole abdomen here. About any pointers, questions regarding the ultrasound images, just let me know and stop me at any points. So, but now there should be something here that should be very indicative of what's going on. If people can take let me know what they're looking in this view.
Are we to just answer verbally, not on their poll, Henry?
No, yeah, verbally. Yep. Don't worry though. When the poll comes, then it will come the big thing. So
Okay, so you just want us to comment now, verbally, yeah?
just comment. Yeah, verbally.
Yeah, so we're obviously seeing, I mean, you can see aorta there at the bottom of the screen, pulsating away, curvy view. You can clearly see what appears to be loops of bowel. You know, there's a degree of kind of horstration. There's some interloop free fluid, little tanga sign, triangular tanga sign. And then an ineffectual peristalsis, sort of to and fro motion. You can see some slight bits of kind of fluid and gas mixed together, content surging through, but not really effectually peristalsing. So I guess you'd be saying this is a degree of obstruction somewhere.
Yes, perfectly said. Figure well summarized. So, so that was kind of a thing. So, got a couple of other views to try to figure out, but you can see how big this, the concern for the bowel obstruction is because it was kind of everywhere we looked. So, um, and a couple of more pictures, just basically seeing this is more lower in the abdomen. You see the aorta right there, so just overtaking basically most of her abdomen. So that's what's kind of extremely, concerning for, again, you see in the back and forth motion, which is highly concerning for obstruction. And basically you don't even need to measure this one to know that is in the upper size of normal, that basically would be indicative of bowel obstruction. So got a abdominal CT right away after those findings, and basically showed bowel obstruction, something that we saw already. Here we do CAT scans to confirm these. A surgeon would not take just our ultrasounds and just say, yeah, that looks like it is. So basically, the CT was done after that. So due to the age of the patient, because I saw she was transferred to the adult hospital, which is we're very spoiled here because adult hospital is literally across the street from us. So basically, it's just they take the patients down through a tunnel and they go right to an adult hospital. But basically, there was a bowel resection, and the final diagnosis of this was mucinous adenocarcinoma. So that ended up having some bowel obstruction, but it was descendant from this mass that came about. So it was a very interesting. I think it was this case was written up by one of my colleagues as well, but very interesting case I will understand. I'll let you guys know why we picked this case to start this presentation. So the second case I'm going to present before going into the lecture. So it was an overnight shift, and then here, it was a very busy shift. It was in a winter time, so I walked into my overnight, and there was over 20 people in the waiting room waiting to see me, and the whole department was full. And then we were also boarding, which means that there's the hospital was full, so admitted patients were staying in the emergency department. So it's a very fast-paced shift and very busy shift with a lot of factors to consider in as well and through that. So I walked in, I got this patient as a sign out, so it was partially completed by my colleague. This patient was being worked up by one of our best practitioners here as well. So my attending told me that, the advanced physician was taking care of this child, and that workup was sort of like ongoing. So it was a 16-year-old girl, otherwise healthy, that presented here after being transferred for appendicitis. The diagnosis was made on ultrasound at the outside hospital and came here essentially for surgical evaluation. There, she presented with a history of abdominal pain and chest pain. There was associated nausea and vomiting. There was no fevers. And the chest pain was evaluated on a previous visit to that same ER, like the previous week. There was no shortness of breath or syncope that associated with it. There was intermittent palpitations per the patient. An EKG was done, but it was normal. So in the previous visit to that, so 2 weeks from that, it was treated as reflux, and then basically came the following week with abdominal pain. Chest pain had subsided, but then basically they were worked up for the abdominal pain. Exquisitely tender and lower quadrant, got the ultrasound that was consistent with appendicitis, and then transferred to us because they were in an outside hospital for adults. So physical exam, when she arrived to us, vital signs were temperature was 97.2, heart rate was 96, respiratory rate was 20, blood pressure was 109 over 75. In general, she appeared very uncomfortable. Lungs were clear. There was no wheezing or crackles. Heart was normal. There was no murmurs. And abdomen was effusively tender, but it very exquisitely on the right lower quadrant. So here, just because of we had multiple cases, and then the early part of my career, I focused on appendicitis. So we got to see that a lot of our ultrasonographers, basically ultrasound technicians in our hospital, are very good at what they do, and they're very good in compared to the rest of the country and actually the rest of the state. So we noticed that there was a lot of false positives, false negatives when they came diagnosed with either normal ultrasound or ultrasound consistent with appendicitis. So basically, it's very common or actually routine for whenever we get a patient from the outside hospital with an ultrasound that we repeat our own because we found, unfortunately, there was a lot of false positive, false negatives on outside ultrasound. So appropriately so on this patient, we repeated an appendix ultrasound, and this is one of those cases where it was a false positive and the appendix was normal. And then when I mean ultrasound here, I'm referring to the radiology performed ultrasound, so not a bedside ultrasound or POCUS. So our repeat showed normal appendix, and then there was a large amount of free fluid in the abdomen and pelvis. So they said clinical chlorate, but consider abdominal CT. So the advanced practitioner at that time took that, and because of the level of pain that the patient was in, when go ahead and order the abdominal pelvis CT, and then basically showed just free fluid in the abdomen and a small right pleural effusion. So surgery was consulted. But the other thing that this is where I give credit to my advanced practitioner was that there was the history of just chest pain that was reported, and at this point the patient was reporting and started complaining some intermittent chest pain along with the abdominal pain. So she ordered an EKG just just to see if it was the same as the previous ones that were done. So that's what I'm showing you guys here. So if you guys can verbally tell me what you guys think of this EKG that was handed to me, and this is when I got involved because she came over and gave me this electrocardiogram. So what does everyone think this we're looking at? Yes, simple question is really, does it look normal or abnormal for an EKG?
So I put it in the chat, Henry. I don't know if you can see. So I said that you've got a PVC, and then at times you've got some ST segment elevation with what looks to be probably some reciprocal de depression.
Yep.
So certainly features that are abnormal to me. You've got
Yep.
some fairly low voltage complexes throughout.
Yes.
So yeah, I'd be echoing this person.
Yeah. So I just like to share, so and unfortunately I can't see the chat, but so yes, just as you said, David, so diffuse low voltages, frequent PBCs, and diffuse SC segment changes. So I stopped everything that I was doing at that point and grabbed the ultras machine and sort of went towards the patient. And then this is what I started seeing. So as you can see, this is a subcipher viewed where the probe is right in the subcipher area, indicated towards the right, and sort of our reference is essentially the liver that's at the top of the screen, and then you see in the heart the right ventricle and the left ventricle here. In this view, basically my main thing is to look for pericardial effusion, and as you can see, there was no thing noted on this at all. So there was no pericardial effusion, so that was kind of a little reassuring in that sense. But then, just for the sake of time, and because this is, I've got plenty of other cases to go. Basically, I'm switching into the parasternal short, which is when your indicator's towards the right hip, or depending on which way you put the cursor on that, and maybe towards the left shoulder. But this is sort of where I'm looking at the left ventricle and looking for function. So very quickly, can anyone tell me this looks like a happy heart that is pumping away, or it looks abnormal?
Hugely unhappy.
Yeah, looks very unhappy. So basically a decrease, basically if heart failure is what we're looking at. And the interesting thing about this patient was that you see that, I qualified it as forced squeeze. The blood pressures and heart rate for this patient kind of didn't vary that much. As you saw when the patient came in, during that time, it was normal, started trending down. Uh, the lowest it got is 92 over 71, but it's one of those things that where I told the residents that, oh, never just rely on those vital signs. If there's other things going on, they should act quicker. So, luckily, she never got hypotensive at any point or anything like that. So, the workup, essentially, this is one of those where I call my cardiologist, woke him up at whenever I got to like 2 in the morning when I actually did this, and they woke up very distressed and ran because the cardiologists are not in house. They come from the from their house, so they immediately got in the car and came to the patient and did a stat echocardiogram. They wanted me to start her on pressors just because as just to help her out. There was never a hypotension as you saw when I showed you in the previous picture, and she was admitted to the PICU for further management. Her final diagnosis was myocarditis with severe cardiac dysfunction. So I think her ejection fraction on there was like 15 or 20. So, and then to the points, because this was, I think, almost not 2 years ago, there was no etiology, that was determined. They did all kind of fancy tests, but nothing came back. Luckily, though, after about a year, her function returned to normal. So that was very, very, I feel very happy for that patient. So this is the next question that I want to kind of show everyone. So these cases are examples of, the use of POCUS for the win, cognitive biases, or malpractice. Oops, sorry, I went too soon. So if people can answer, and then we'll move on from there.
Henry, while people are answering, can I ask,
Yeah.
would so the cardiologists at your institution, on the basis they said to start pressers, was that just on the basis of you relaying your findings? They hadn't seen any of the images themselves. Obviously, you didn't want to wait for them to
Yeah.
perform their own echo. How does that play out normally?
So I have a very good relationship with our cardiologists. They actually trust our bedside ultrasounds, partly because everything gets uploaded to the patient's chart, so they can be in their bed or just pick up their phone, or I mean in the computer, and actually see our images. I have a because I was in this case, they know I was a director at the time. So then, as soon as I told them, I was like, "This looks hard. This looks horrible." Basically, they didn't even tell me. They just said, "Hey, based on that, start our pressers. I'll be right there." And they have to be here within around half an hour. So by that time, I started the pressers, and then they came in with the echocardiogram. So when it's overnight like that, the cardiologists themselves will do the echo. If it was during the day, basically we have technicians around that will do it. But for overnight, for those cases, the cardiologists themselves do the echoes. All right, so everyone thought it was Pocus for the win, which I agree, but the other thing that it is was cognitive bias. So the examples here, and then I'll get to what cognitive bias is. Basically, were that these case depicted was anchoring bias and confirmation bias. Anchoring bias is we have a tendency to perceptually lock into salient features on the patient's initial presentation too early in the diagnosis process. So essentially, the in the beginning, we were really focused for the first patient of the fact that they had a history of cannabinoid hyperemesis. So there was a delay in a little bit in the care because essentially they all thought because that was her like maybe six or seven visit to our ED for the same condition, and basically with previous workups that were negative, and basically it was all the fact that it was just cannabinoid hyperemesis and she never stopped smoking. So that was sort of what people thought in the beginning for those first case, for the first case. For the second case, it was obvious basically that we had a confirmation bias because we had an abdominal ultrasound that depicted appendicitis and came in here. And basically we kept going down the hole to trying to confirm the appendicitis. Probably could have done without the CT if we could have acted a little sooner. But those are sort of like the presentations of the type of biases that we have. So the presentation is battling cognitive bias with point of care ultrasound. So that's what I'm going to be talking about using cases for of ultrasound. But then I'll tell you why I use ultrasound to why I give this title to this talk. So second question I'm going to ask is want to see what type of if there's any training or anything that's been going on that you guys have participated in regarding cognitive bias in clinical medicine. So if you guys can shoot a couple of answers in the poll. All right, so I'm glad that for the most part, everyone's aware of at least the cognitive biases, and then important to know because basically cognitive biases are a systematic pattern of deviation from the norm of rationality and judgment. Cognitive biases are ubiquitous and do not correlate with intelligence. So just because someone's really smart doesn't mean that they're free from cognitive biases, sometimes that actually does not help at all, actually. So it was actually been recognized since the 1970s, and about 100 different biases in general have been studied, and 40 have been identified in medicine. Not necessarily that you have to be all cognizant, all 40, but there I'm going to go over the most common ones that we battle through in our daily practice, especially in emergency medicine. So in terms of like a little background about this, so medical errors occur in about like here, this is from like probably in the last 10 years, the only one that I could find, 1.7 to 6.5 of all hospital admissions that have some medical errors. This is in the United States, basically leading to approximately what they say, like 100,000 unnecessary deaths a year. And the costs in 2008 calculated because of all the medical errors was $19.5 billion. In 2015, they noticed that 28% of diagnostic errors were related to cognitive errors, and cognitive errors were associated between 6 and 17% of all adverse events in hospitals. So that's basically very alarming to see that, there's a lot of things that if, just like we get training in POCUS to kind of save lives, we should get the appropriate amount of training in cognitive bias because, it's not just like something that's isolated, something that is actually impacting care of our patients. And that's basically the second study was kind of everyone they looked at through internationally what they could find. Medical errors were like the big four ones where people noticed were vascular events, infections, cancers, and neurological disorders. That's when, whether it was by diagnosis, delaying treatment, or identification, those were the big four that were sort of identified where the most amount of medical errors occurred. So why does cognitive bias matter, especially in the ED? So emergency medicine has been labeled as a natural laboratory of error. As we all know, we have a lot of stressors. So basically, what one things we love about emergency medicine, especially me, is that it's variable. Basically, it's not the same thing every day, right? But unfortunately, everything's unplanned. So we're not going to sure what type of shift we're walking into, whether it's going to be an overnight shift, whether it's a day shift. So like basically our workload is very variable. So it can be very stressful at times. Sometimes it can be a little easier, but you just never know sometimes what you're going to get when you walk into the ED. In our environment, there's constant interruptions, as we're all aware of. It's very chaotic, and basically it demands us to have a rapid understanding of the situation and kind of work fast. Because of the unplanned variable, then constant interactions, the chaos and everything, it leads us to sort of like save ourselves by doing mental shortcuts and stereotypes that can lead to errors. So that's kind of like what our process goes through, and then that's kind of the main thing that we kind of have to deal with in the ED, and that's why it's very important for us as ED physicians is to be aware of these cognitive biases because they play a huge role in our decision making. And this one did not load, so I'll skip it just so I'm not sure it did. But essentially, this is sort of what happens in our brains, and this is kind of studied in a few articles. So when we get a patient, basically we get the history, and then we start to detect a pattern, whether it's recognized or not recognized. Then we go into what they call a type 1 fast reflective process. And then we basically make up a diagnosis based on those experiences. And then we have the type 2, the slow analytic process, that's when something's not recognized. So the first one, the type 1 fast reflective process, it's very intuitive, automated, efficient, but unfortunately, as you guys can know, is prone to failure because if we recognize a pattern, although sometimes it's, a bronchiolitis is a bronchiolitis, but then it could be fibromyocarditis if we don't listen to the cues of the patient or we miss something in there. So that's the only thing that, although we do need this type 1 fast reflective process in our practice in emergency medicine, it can lead to some serious problems with diagnosis if we're not aware of things that can go wrong with it. The type 2 is more deliberate and analytical, but it's resource intensive. So it's when we don't know something, obviously we know something that takes us more time to pause, trying to figure out. Sometimes we order more extra tests just because we don't know what's going on, and then try to like, synthesize all the information that we got and then lead to the diagnosis. So So the first other question that I'm going to ask is here. So just to gauge in terms of where you guys are. So a bat and a ball costs $1.10. The bat costs one more than the ball. How much does the ball cost? So let's see what people think. So, give you guys a few more seconds to answer this question. All right, so the correct answer is actually 5 cents. I'm actually very surprised a lot of pick 80%, so people are awake and thinking things thoroughly. So usually when I ask this question, and the first thing that most of the time goes, or even up to 50 to 60% of the time I see is that they automatically pick 10 cents. But here, like, and that's because usually you're like easily subtract, you're like 110 minus one, that's 10 cents, but it's actually 5 cents when you actually do the math correctly and you think of the process very thoroughly. So, that's a good job by you guys. So, the main thing is sort of balancing out type 1 and type 2 thinking, right? Because we do need the type 1 because that's the only way we can manage the workflow in our ED, but we also don't want to rush either. So we want to have this sort of balance between type 1 processing and type 2 processing in our clinical practice. So, any questions before I go on to case three? And sorry if I can't read the comments if there are some comments in there. So, but I just want to give a pause before we go to the next case.
Yeah, we're good. There's nothing in the chat, Henry.
Okay. So case three. So it's a 3-month-old referred by a pediatrician for fussiness. It was one episode of non-villus and bloody emesis the day prior to presentation. Was evaluated by the pediatrician who noted a right femur tenderness with movement. There was no history of trauma and otherwise review systems was negative. Physical scan was otherwise unremarkable. So when the resident presented this kit to me, again, it was an overnight. So everything happens in overnight. Interesting in my eyes. So um, the resident came in and said, "Hey, this kid looks great, looks fantastic. I think there was an overcall by the pediatrician." So when I went in, though, there was a very subtle pain with hyperflexion of the right femur. It was just one of those times where you have to spend a little more time at the bedside with the patient to notice that. And the resident was quite surprised because, they were like, everything was normal in their eyes. So because of the concern of the pediatrician and my finding, I did X-ray of the right femur that you guys see in there. And can anyone, and this is verbally, comment on whether if they see any abnormalities or if there's question marks or if it looks like a normal X-ray.
Is there a spiral fracture in that lateral view? Kind of the top third?
Right there? Yeah. So that was a question mark, whether that was because it was just on the lateral film, but the X-ray was actually read as normal. But Nigel, I think that was you that would comment. I was a little unconvinced. So then I decided to do the ultrasound. And what I found was, initially I was looking for maybe a hip effusion, but then I was very interested in what that linear lucency was. And this is what I'm seeing here. So if you guys follow my marker, so this is the bone because it's hyper echoic, creating the shadow. So you see very nice linear, but right here, there's a little bit of a discontinuation in the cortex that we were seeing. So that was the previous one was a longitudinal section. This is a transverse or short axis, and that little discontinuity is noted right in this area. So very subtle, not very. So I took a bunch of. So one of the things that a lot of people sometimes call this are these like blood channels or anything there, but I did flow in that area, and as you can see, there's no movement in that area. So actually, one of those times where I have a very good relationship with our radiologist. I called them in the middle of the night and I say, "Hey, can you review my ultrasound and can you agree that there's a fracture because that basically leads to like a fracture in a child with a no history, so basically a non-accidental trauma." So after talking to the radiologist, he reviewed the pediatric radiologist reviewed the X-ray that was read by another radiologist and looked at my images and agreed with me. Said, "Henry, that I agree with that. That's a fracture." So we went ahead and did the non-accidental workup. With in here in the United States means getting a lot of blood work to rule out for any type of bone disease or any type of bleeding disorders, doing a skeletal survey. So all that was done, and the patient was admitted to the hospital as well. So in the month follow-up, basically the X-rays was repeated because that's what's commonly done here, because there was no other fractures while the patient was admitted. There was no other injuries detected with all the studies that was done. So they repeated a skeletal survey in a month, and they did notice that healing fracture there. So that was basically the final diagnosis in this patient was a non-accidental trauma. Fortunately, they couldn't determine who inflicted the injury on the patient. That was never sort of resolved, by the time that I follow up with this patient. So the resident in this case, the cognitive bias in this, what I'm going to do is I'm going to present a case and show you how essentially someone in the medical team fell into a cognitive bias that led to sort of that could have, go to a loss, but then obviously point of care ultrasound can sort of like kind of saved the day. So in this case, the resident came in. She had premature closure based on her, her exam was completely normal. Then she had a search satisfaction error, which means that there was, negative X-rays, so they were completely fine with that, and sort of was gonna will need to discharge the patient. And then, because I had that little question in there, I used ultrasound and basically ultimately came to the correct diagnosis on that patient. So something to consider. So always being able to be open to the diagnosis before calling it off, and then never. That's one of the things that I notice especially with emergency medicine residents, is that as they go in their careers, they tend to have premature closure on a lot of the patients. So that I always try to make a point to tell them about cases or tell them during when they're presented to me about not premature inclusion of their diagnosis. All right, so moving on to another case. Case number 4 is a 9-year-old with otherwise healthy that came with abdominal pain for 2 days, has some non-bilious non-bloody emesis, no diarrhea, and no fevers. Vital signs were otherwise unremarkable. Basically, the kid was tender and lower quadrant, and the rest of the physical exam was negative. Uh, Rheology ultrasound showed a normal appendix, but bowel wall thickening. And this is one of the cases where we're spoiled in my emergency department because the triage nurses, the ones that see the patient first, if they see something that they can order something ahead of time to kind of, to improve the pace of the department. So if they feel that the patient has a tender bilateral quadrant, they immediately order an appendix ultrasound. And our radiology's technicians are very good, so they during the day they can get most studies done within half an hour. So if a kid comes in triage with right lower quadrant pain, basically he goes sometimes gets an ultrasound before I even see him. So that was one of these cases where this patient got a right lower quadrant ultrasound looking for appendicitis. But so a normal appendix, but then they commented on this bowel wall thickening that they saw. So again, went in with the ultrasound to kind of take a look in that area. And then what we're seeing here is we're seeing a sagittal view in the pelvic region where this area right here is your bladder as sort of reference. And the area of interest is right here. It's this kind of like donut area here where you see in is bowel, but looks a little more thicker than the rest. And so that was why they were commenting on the ultrasound. So decided to take a quick look there. So I did not, although I see bowel, but it was very isolated to have this bowel wall thickening that is here, in that area. And then I took a couple of uh, measurements and got close to like basically a centimeter in dilatation in that area. And so then that prompted me to call the gastroenterologist for a consult. Obviously, I knew they wanted lab, so I got some lab work. White blood count was 15, sedimentation rate was 14, and the C-reactive protein was 1.4. So just very mildly better, nothing really bad. So I discussed this case with the gastroenterologist. They said, you know what, because in the setting of probably vomiting diarrhea, it's probably gastroenteritis, so a little bit of inflammation there. Just have them follow up in like 2 weeks if they have persistent symptoms. That was sort of like the thing. And kind of the resident I was with kind of agreed. They were like, they didn't want to make a little fuss about this. They were like, it's just a very minor finding. It's probably just gastroenteritis, and kind of wanted the patient right away. This same patient came in 9 days later, actually, to the ED. And luckily enough, I was working. So the parents reported to me that he got a little bit better when he left, but then basically started vomiting again, basically like a few days later, and again with the right lower quadrant pain. At that point, I saw him and I was able to do an ultrasound first. And then I went, since I knew exactly where to find his inflamed bowel, I went straight into that area. So in this skin, this one I'm seeing is in the transverse view of the pelvic area. And you see in the bladder, kind of in this area here. And let me just try to pause it. And you see in this donut shape right here, which is basically you can just say that it's gotten thicker since he was there beforehand. This is a sagittal view of that area. And if you guys remember from the previous, before it was more located in this area and it just occupied this area here, where now it was bigger and more, looked a little more angrier in there as well. So and this is when I switched over from a curvilinear to a linear transducer, and you can see how thick this bowel wall is right here. So you can see the difference. I mean, this is from the second visit, so it got a little bigger in terms of dimension here on the side, in terms of from the previous one, because I think the highest I got was about 8 millimeters in the last one, but you can see that this one was significantly there. So repeat labs showed a white blood count of 17, ESR was 8, and CRP. So actually everything got better, but I talked to GI again, and then they wanted a CAT scan, as sometimes our specialists here got. She was diagnosed with Crohn's disease based on the CT, and that was her diagnosis. So basically, that was her first flare up of that. So here is it's an example of the cognitive bias called availability bias, which is the disposition to judge things as being more likely or frequently occurring if they rarely come into mind. So in this case, the first time that they went there, they were like, oh, this is gastroenteritis. It can be there, so it can't be anything else. Just send them home. That was kind of the ER resident that was with me and sort of the gastroenterologist fellow that was there. And on the second visit, they still were not, convinced, and they wanted a CT, basically that could have, but to come into that. So those were the biases that were an example of that case that shows. There's also representative bias in that case because there's a tendency to significantly overestimate the likelihood of a diagnosis because the presentation has more features. Again, in this case, everyone thought it's just gastroenteritis. And, most of the time they'd be right, but that's kind of the main thing with cognitive biases is that if it can just be slowly creeping up on you, and the more you just do the shortcuts, the type 1 process, it can lead you into a misdiagnosis of the patient. Case 5. So case 5 is a 7-month-old with otherwise healthy who presented with fever and decreased activity. This was in the height of COVID. So I'm going to ask you guys to think about, put your thinking hats as you were practicing during 2020, 21 actually. So that's where this case comes from. So In this case, he came in with fever and decreased activity, was evaluated 4 days prior and diagnosed with viral illness. COVID was negative at the time. Persistent fevers and worsening activity level, and that's why they came in because of that. And at the time that they came in, they were also having increased work of breathing. Physical exam as febrile, tachycardic, tachypnic. So basically everything looked just wrong with this patient. So it was very toxic period. Fontanelle was flat. It was not bulging. And then the neck was soft, supple lymphadenopathy. And again, the only thing, again, this was if you were to have asked the ED resident, they wouldn't have noticed any type of sort of like abnormalities with the neck. But again, for me, the patient appeared to be just in more pain with any type of neck movement for me. So, like usually, like like if you like pick them up and do something, they're like, and specifically try to like when they move their neck, this kid just seemed to be a little off, like in terms of whenever they try to move their neck, which was a little bit concerning to me. But I didn't, and the rest of the exam just basically just saw an ill, the overall picture was you have a very ill-appearing kid that's in front of you. So in this kid, obviously septic shock and the MISC workup was initiated. So similar lab work in terms of was work at the time, if you guys remember what we did for MISC. I got a CT, I mean, a X-ray of the neck just because I wanted to see if there was anything there, looking for maybe an indication of retropharyngeal abscess or anything that could be causing that sort of like, the uncomfort level whenever someone tried to move the neck or try to move it to the side. So that's things I was looking at. But then I went ahead and did a cardiac ultrasound because with any kid who's in sepsis, I tend to start doing a cardiac ultrasound because I want to make sure that the pump is working. So I want to make sure that the heart is squeezing appropriately. So usually I always start with a cycle view, as we're seeing here for reference. At the top of your screen is your liver, and here you're seeing your heart. And then there's no evidence of pericardial effusion on this patient that was noted. Um, this is trying to look at the IVC that's going there, and it's very flat, not really much movement there as well. Parasternal lung of the patient, will look in just to confirm that there's no pericardial effusion noted, and then basically you can see that the heart is just very, like going really fast at this point. The main thing though was when we go to the parasternal short, looking at the squeeze of the heart, which looking at the left ventricle, you can see here that there is some decreased activity there. It is going really fast, and that's kind of really hard to like appreciate, but it has some decreased activity. So I called it depressed at the time. Now I called it moderate squeeze at the time. That's what I called it. And that's what we were seeing with MISC, and this is what the literature showed that you were seeing some decreased activity, not too bad, but there was a little bit of decreased heart activity. So that's what I noted on my ultrasound. So, and then a four-chamber review of the ultrasound just showed that basically both was unremarkable. I was just looking for any of the signs that would explain the decrease in function. I went ahead and did a chest ultrasound to look for B lines. So that's what I'm looking at right now. I used phase array probe, and as you can guys see, there is some B lines going through kind of everywhere there as well. So all this was giving me bad vibes and indication of possibly heart failure on this kid as well. So all the labs that we got back. So this is everything that's there. And again, this was a combination of sepsis labs and MISC at the time. So you can see that the white blood count wasn't really that high. It was a little low, lymphocytic predominance, very hard CRP, very high ESR. Troponins were fine. The PMP was elevated 25,000. The dimer was really high. Fibrinogen was high, and ferritin was also very high. So the question that came into our minds was whether or not this is MISC or should we working this kid up for something else. Main question was, since he got kind of everything, is this kid warrant LP or not? So what will you guys do if for this patient, right now? So the main question was, do you admit him because he has some criteria that fit the MISC at the time, or do you continue treating this kid? Because obviously you got already blood and urine. The final step in the septic shock protocol was doing a lumbar puncture, so that was kind of like the main question that we had to deal with at the time. Is like, do we just admit him and treat him for MISC, or do we do a performer lumbar puncture? So, what does any comments on what you would do? Unfortunately, I can see the comments. So, uh, David, if you're seeing any comments there or have any thoughts on what you would do in this for this patient, let me know.
Guess you could theoretically make a case for either. Everyone's on the fence as well, I guess.
Yeah, yeah. So that was that was kind of everyone's point of view. I decided to do the LP just because, like as I said, it was one of those things that I always say it's better sometimes to be lucky than good. So, but I did the kind of the LP. Um, I talked to ID as well, and then they wanted me to do skip steroids to cover MIC, and then but then basically I got the LP and I gave antibiotics and I sent them upstairs. And this CBC, the LP showed essentially meningitis, and the kid had actually a strep pneumo. So. Had a really bad course, unfortunately. The head ultrasound had a subdural abscess that when after getting an MRI showed multiple effusions. Unfortunately, couldn't be surgically intervened. And then 8 days after admission, there was a pulmonary infarct of the left basal ganglia in the left thalamus. And he was discharged after a very prolonged stay in our hospital. And then he developed some hearing loss and developed some hydrocephalus as well. So, you know, my when I was looking back in terms of like any cognitive bias that I had done, it's like, it's fixation error, like where we like, because there was a lot of discussion before I actually decided to do the LP on this kid, whether this is MIC or not. And there was a lot of people involved, a lot of cooks, and maybe I should have ordered the antibiotics sooner. Maybe I should just pull the trigger and done the LP sooner. But this was, a conglomeration of multiple things. So we're in MIC mode, we're in COVID, very tough ER in terms of patient workload, very demanding. So basically, there was multiple things that went wrong in this kid, but whether or not we can suffer from that fixation error where we want to think it's something and then kind of go from there. So there was an error in that. So in terms of really quickly to finish up and overall in a 2016 systematic review, in terms of the most common cognitive bias there in the ED are anchoring effect, which we call information and availability bias, which I demonstrated. And overconfidence bias, which is something that I covered, but it's kind of self-intuitive, is when you're overconfident about your diagnosis and close your diagnosis. So kind of premature closure similarity in there as well. And tolerance to risks, basically whether or not you don't want to take the risk to do that. So you're like a cowboy where you're like, this kid's gonna be fine and just let him fly. So again, another premature, they kind of like overlap in terms of there, but those are the most common ones. These are the other common ones that are seen in the emergency department. I went through most of them. So the anchoring, the confirmation, availability, and the framing effects. This is one that I wanted to do is essentially when this we suffer from when either someone's referred to the ED by someone else or the triage nurses, put this kid as something else. And our residents are commonly like, the tunnel vision goes, oh, well, someone else thought this was that. And then that's why they prematurely close their diagnosis. So those are things, all these biases are something to be mindful of and keep in mind. So um, I think we've run a long time, but usually I ask for stories where people have maybe one or two stories that we can hear where you find yourself having some cognitive bias. But based on time, so I'm just going to skip on that and just going to close there. So essentially, is what can we do about this? So based on the literature, there's a rule of three. So explicitly rule out of three diagnoses or treatments. So in your head, this is what I try to implement to our residents. It's like always think of three diagnoses and three treatments. So never just say, oh, this is that and kind of go from there. Even for an otitis media, I tell them that because there's a lot of times where I'm like, did they have conjunctivitis? Because maybe they have otitis, conjunctivitis, otitis media syndrome. So then they close prematurely close their diagnosis with that. So, and summarizing aloud is something that was found to be in the literature that was helpful. So when you're talking to yourself, so that's don't feel any judgment from that. Other strategies that have been noted was that is always kind of these are the questions you should be thinking to yourself. Was the diagnosis suggested by the patient or a colleague? Did I consider causes besides the obvious one? Is this patient I do not like or like too much for any reason? Have I been interrupted, distracted while caring for this patient? And am I stereotyping the patient or the presentation? So these are just like the constant questions you can have in the back of your head while you're seeing a patient. But the main thing is what they call a diagnostic timeout. And this is why I chose the title of my lecture is because there is many ways in the way you can have diagnostic timeouts. Mine is using the ultrasound machine. So mine is a point of care ultrasound. So is I that gives me a second time to go there to the patient and kind of think of other things. And then I have my mental timeout, think of three other diagnoses, and it lets me to calm down. When I have to ask, when I'm giving this lecture to other people, one of the other, there's fascinated in terms of what diagnostic timeouts they use. I remember one resident told me that his diagnostic timeout was actually listening at the lungs. And he was like, seems like, sometimes we care about the lung exam. He's like, but I always take my long time with my lung exam because he's like, no one talks to you because you have your stethoscope on. And he was like, and whether I'm listening to abnormalities or not, but I always take a long listen to the lungs because that's my diagnostic timeout. That's when I think about if there's anything else I'm missing, whether someone else, all the kind of biases. So that was his mental check. So um, everyone can have a different diagnostic timeout. Mine is point of care ultrasound. So that's kind of like the main thing. That's why I chose the title is because it's battling cognitive bias with ultrasound. Because in most of the cases, point of care ultrasound helped me go past the cognitive bias and then kind of make the correct diagnosis. So in summary, so use the rule of threes, summarize it loud, always seek disconfirmant evidence, ask your team of experts, if there could be something else, and consider are the circumstances biasing your thinking, whether this is fast-paced and you're trying to just get out of the job, whether you're trying to just move through things quicker, and then always try the perspective hindsight, and that's pretty much it. So questions or comments, personal experiences?
Thanks, Henry. I'll jump in. I thought